day, Dr. Alando and Dr. Mitchell. My name is Kempes Chan. Welcome to my CILE presentation. This is a narrative review on prescription opioids in acute pain management, a catalyst for ongoing non-medical use in North America. Acute pain affects millions of Americans. In 2016, approximately 100 million American adults were affected by pain. The Institute of Medicine's report on relieving pain in America described pain as a public health challenge due to its prevalence, seriousness, and the importance of prevention at both the population and individual levels. The undertreatment of pain can lead to depression, irritability, sexual dysfunction, sleep disruption, and adversely affect the patient's quality of life. Prescription opioids are part of the clinician's armamentarium for dealing with pain management. However, if mishandled, there is a risk of addiction, overdose, and even death. During the period 1999 to 2018, 232,000 deaths have been attributed to opioid overdose involving prescription opioids in the United States. In the study by Butler et al., 59% of patients surveyed stated that their initial exposure to opioids was from a prescription. Medically exposed subjects in the study reported non-medical use of opioids to get high or avoid withdrawal within just 6 to 12 months after their initial exposure. The ED is often the source of a patient's first encounter with prescription opioids. In this review, I aim to determine whether prescribing opioid analgesics to manage acute pain in the ED also leads to ongoing non-medical use. In my research, I used Google Scholar, ScienceDirect, and PubMed databases. I also used the New England Journal of Medicine, the Journal of Pain Research, and the American Journal of Emergency Medicine. Finally, government resources from the CDC, the National Institutes of Health, and the National Institute on Drug Abuse were also used. For my inclusion criteria, I used studies where patients were prescribed opioids either in the ED, literature about alternative therapies to opioid drugs, and papers published between 2001 to 2022 to be able to review the most up-to-date studies published on this subject matter. I excluded studies involving non-prescription drugs and illegal drugs. Also, patients under 18, since this demographic has a lower rate of opioid use, and also papers that did not pertain to demographics in the United States, so papers outside of the United States. In this review, I found that the various studies were divided on the issue of whether a prescription for opioid analgesics for pain management leads to ongoing use. Punches et al., Friedman et al., and Doust et al. All concluded that a prescription for opioid is unlikely to lead to ongoing use in most patients. However, Hopp et al. And Hurd et al. Agreed that opioids administered in the ED were associated with an increased risk of ongoing use. Nonetheless, ongoing use of prescription opioids could provide a gateway to heroin use. For patients who become long-term opioid users, the effects of persistent use can be deleterious. One such effect is neonatal abstinence syndrome, NAS, a type of opioid withdrawal in babies. Each year, 20,000 babies are born dependent on prescription or illegal drugs. A possible solution to mitigate this situation is the use of alternatives to opioids, or ALTO approach. In this approach, non-opioid options are used as first-line therapy for pain management. The study conducted by Duncan et al. Showed that the ALTO approach reduced the administration of opioids without compromising patient satisfaction scores with respect to pain control. Some of the similarities amongst my studies: 6 out of 10 studies analyzed used retrospective study designs. This type of study utilizes existing clinical data, which is relatively inexpensive and an efficient way to collect pilot data. However, some risk factors may not be identified in these retrospective studies. Both Punches et al. And Hopp et al. Called for further research being done using prospective study designs instead. 3 of the studies noted that prescribing higher doses of opioids to patients increases the risk of long-term opioid use. Those are the similarities, some of the differences. In framing the study designs, the various studies used different definitions for ongoing opioid use and also opioid naive. The way the studies define these terms would have affected the quality of the data and ultimately, obviously, the study outcomes. This could be also considered a limitation of the studies. Therefore, I suggest that a universal definition of these terms should be established when conducting any future studies of this kind. There is a vast difference in sample sizes used in the various studies as well. Butler et al. Used a sample of only 59 patients, while Barnett et al. Had a sample of over 300,000. Sample sizes that are too small reduce the power and thereby reduce, obviously, the statistical significance of the study. Conversely, overly large sample size, like the one Barnett used, can transform just minor differences into statistically significant differences when there is no clinically significant difference there. Some of the limitations of the study: some studies relied on self-reported data from patients regarding their opioid use. Social desirability bias could have affected the way patients answer these questions, thus resulting in a lower proportion of persons reporting misuse of opioids. Also, many of the studies looked at patients from only a few EDs or only a single state. As such, the studies may not represent other EDs or other demographics, and the patterns of opioid exposure that they reported will not be generalizable. A universal definition should be established for all researchers when determining whether a patient is considered a persistent opioid user. The various studies used different definitions, which could have affected the type of patients included in the studies, and may have excluded some patients who they should have represented. My recommendations: additional research is definitely needed, preferably using prospective studies to produce results that are more generalizable. At present, each state has its own prescription drug monitoring program, PDMP. So interstate collaboration is needed in these monitoring programs. This is necessary so that providers can ascertain whether patients fulfilled or filled prescriptions in different states. And this will now give a better idea of how patients access their opioids. Greater consensus is needed among physicians on prescribing practices also to avoid potential issues associated with high-intensity prescribing. Medical students and medical residents should also be adequately trained on the risk of high-intensity prescribing. The implications of long-term opioids to manage pain should be discussed with patients. Alto protocols should also be discussed so that patients have a greater options, more options to manage their pain. Finally, physicians should be more cognizant of their patients with risk factors to the development of OUD. For example, mental health issues come into play, race and socioeconomic factors come into play. So physicians are then able, based upon these risk factors, to adjust their prescribing behaviors and thereby reduce the risk of opioid use disorder. In conclusion, my review of the literature has revealed that there's currently a mixed bag of evidence to suggest that prescribing opioid analgesics to manage acute pain in the ED leads to non-medical use. Additional research is definitely needed in this area to get a better grasp of this situation. Thank you for giving me the opportunity to share my presentation with you. And